So we've talked about the two different classifications of renal failure, how one of them is acute kidney failure, acute kidney injury. That's what we've been talking about in all the videos up until now. And now we're going to talk about chronic kidney disease, which is just a different classification of renal failure. Anytime you see acute, you are thinking something that is sudden onset. It has not been building for a long time. I think I said this in another video, but it's the difference between a heart attack, that's acute, an acute MI, and chronic or congestive heart failure, where it's something that it's a chronic condition that has been progressing, okay? It's the same thing with the kidney. You have an acute renal injury or acute kidney injury is something that has just happened to the kidney or to the blood leading to the kidney. Chronic kidney disease is progressive. And what that means is that nothing has necessarily happened to the kidney in terms of a crush injury or anything that suddenly damages the kidney. It really is just kind of a progressive deterioration of nephron function. So the nephrons are just slowly dying, or they are slowly not working. You can have a reduction in the number of nephrons, and as you age, that does happen. Unfortunately, chronic kidney disease is irreversible. In fact, most of the time, you don't even have symptoms until you have a 50% reduction in your kidney function. So you don't even know necessarily that, unless you're already having your creatinine monitored or your BAUN monitored continually, you may not even know that you have chronic kidney disease until you've lost already 50% of the kidney's function. So I just want to see if I'm missing anything here. Okay, so the GFR, and we'll talk about this on the next slide, but the GFR is really, really important in chronic kidney disease because because it's a progressive disease. As the disease is getting worse, the GFR is going down. Okay, once you've had a GFR of 60 or less, so 60 milliliters per minute, your glomerulus is only filtering 60 milliliters of blood per minute. It's supposed to be filtering about 125. Once it's been at 60 for about 3 months, that's when we would diagnose chronic kidney disease, okay? And we know that what is that going to do? The kidneys are not working. It's going to decrease your ability to reabsorb substances and to filter the blood. So I know it feels like the videos on acute kidney injury, there are so many more and there's so much to it. And that's simply because the symptoms, the pathophysiology behind it really is the same thing, where sure, the onset might be different, the cause might be different, how we diagnose it might be different, but the reality is that what's happening to the kidney or in the kidney is going to have the same results, whether it's acute or chronic. Now, so acute kidney injury, we've talked about, is a sudden onset. Chronic kidney injury, it's gradual. It takes a lot of time for those nephrons to just die off or stop working. The most common cause of acute kidney injury is acute tubular necrosis, whereas with chronic kidney disease, it's diabetic nephropathy. So certain diseases, you know what, we're going to talk about diabetes in a couple of weeks. So we'll talk about that then. Just know that this is one of the most common causes. So how do we diagnose acute kidney injury? Well, it's a very sudden, the symptoms hit very suddenly. So very suddenly, all of a sudden you'll have an increase in creatinine and you'll have a decrease in urine output. Whereas with chronic kidney disease, it could happen so slowly, you almost don't even notice it. And you can get your GFR can be getting lower and lower and lower. And it doesn't always mean that you will see less urine output. So usually they use the GFR to diagnose chronic kidney disease, okay? Acute kidney injury is potentially reversible. Chronic kidney disease is not reversible. Okay, there's no underlying cause to fix. Once over here, if we fix the thing that's causing, we take them off the antibiotics, if we cure the infection, or if we fix the issue with the blood flow, we can potentially reverse that kidney injury or kidney failure. Here, there's nothing to fix. It simply is that the kidney itself is not, is slowly kind of petering out. The nephrons are slowly, just the function isn't what it was. Okay, and again, that can be caused, often it's caused by diabetic nephropathy. So the mortality rate in acute kidney injury is actually much higher. I mean, I don't know how they decide this, because the reality is most people who have chronic kidney disease are quite a bit older, and they do end up, they do end up dying. So, but maybe something else, or old age or what have you. But the point is, this is very severe and quick. And this takes a little bit of time. The causes, I know it's really confusing because the causes can actually be similar. The issue is that it's the gradual onset that's really, really the biggest difference. So this can be caused by low blood volume, chronic low blood volume that just slowly overworks the kidney, kicks in the renin-angiotensin cascade and causes sloughing, what have you. It can all still, but it's so much slower here, right? And it is irreversible. So I tend to not think of these as two different conditions or diseases. I just think this one is happening very suddenly and this one is very gradual. I hope that helps. I know that a lot of you are having a hard time with that. Just shoot me an email if I've confused you more. So we talked about 3 stages for acute kidney injury or acute tubular necrosis. Here we have 5 stages for chronic kidney disease, and most of this is based on the GFR. So as the GFR goes down, they move to a different phase of, or a different stage of disease. Sorry, just gonna scroll here. So I'm going to talk a little bit about clinical manifestations, because we can do it fairly quickly because they're very, very, very similar. So to AKI. So same things happening here. So if you have a hard time understanding any of this on this slide, if it seems, this makes no sense whatsoever, go back to the manifestations or the first few videos of acute kidney injury and watch them over again, because they explain the pathophysiology of why your BUN and creatinine are high. The biggest thing here with chronic kidney disease, I just need to find there we go, is that it's a little bit, because it's happening gradually, your BUN will rise first and then your creatinine. It's just, you know what, I'm not going to explain why, but it goes a little bit slower, a little bit different. Your urinary symptoms are a little bit different. So you may start with polyuria. So you're just going to the bathroom all the time. Usually it's at night, and they call that nocturia, just in case that comes up on a test. Your specific gravity would be low. And then as the disease progresses, that's when you start to get the oliguria or anuria, and then proteinuria and hematuria, okay? So really, that's the only kind of weird little difference that you have to remember is, is the the BUN will rise first, then the creatinine, and that the urinary issues will start with polyuria and then progress to oliguria and anuria. And again, these things are not black and white, not set in stone. That doesn't happen with every single patient with chronic kidney disease. And I think that's really, really important to acknowledge with all of this stuff that we're learning in real life. It just diagnosing these things and working with them just isn't exactly like it is in the textbook, right? So let's go on. Uremia, we've talked about, right? So as the chronic kidney disease gets worse, you have all of these problems here. Again, I've talked about uremia in a different video. I believe it's the acute kidney injury manifestations video. If you want to go back and take a look at that, I go through each one of these and talk about why you have them. So you can go and take a look at that. Again, we've talked about this. Starts with polyuria, progresses to oliguria, then anuria. You're going to have proteinuria, casts. Casts are just pieces of cells, dead cells, basically, that are coming out in the urine. Hematuria, hyperkalemia, acidosis. This is kind of an interesting thing. Sorry. Normally, because of that buildup of urea, your BUN, it actually can cause your breath to smell like urine, which is, I don't know, I just find that interesting. Oops, sorry. Mineral and bone disorder. I actually don't think I covered this in the other one, but I will cover it in the video on electrolytes. So when we talk about calcium and phosphate, if you want to understand why we have this, switch over to that video and I'll go through it then. Yeah. So that's it for this video, and see you in a minute for the electrolyte video.